Nice to see everyone here again for this edition of Pain Research Working Group. Thank you for joining. Today, our speaker is Dr. Sarah Javier, and I'm going to introduce her in just a moment. I'm going to give just a minute for people to roll in and get her, we want to get her slides set up for her before we get started. Okay, so I think Dr. Javier, I think you're able to advance, but why don't we just try that just to make sure.
Okay.
Excellent. Okay, so I'm going to go ahead and introduce you. So thank you all for joining us today for this presentation by Dr. Sarah Javier. She's going to be presenting on her CDA, which is our CDA-2 application as a works in progress. We're so pleased that she was able to join us today. We really value being able to have early career investigators present their work so they can get exposure to the pain and opioid research community and also get some feedback on their work, which I think people have really told us that they value. So I'm going to go ahead and introduce Dr. Javier. So Dr. Sarah Javier is a postdoctoral fellow in health services research at the VA HSR&D Center for Innovation to Implementation and Stanford School of Medicine. She received a PhD in health psychology from Virginia Commonwealth University in Richmond, Virginia in 2017. Prior to joining CI2I, she worked on behavioral health equity legislation as a policy scholar at the American Psychological Association and evaluated government programs targeted toward underserved populations. Her research interests spanned health equity, chronic pain, implementation science, and women's health. Her CDA-2 proposal centers around implementation of tailored engagement strategies to enhance uptake of evidence-based, non-pharmacological treatments for chronic pain across marginalized groups. I'm going to go ahead and turn it over to Dr. Javier. Thank you for joining us today.
Okay, thank you for the introduction, Alicia. It's very nice to see all of your faces on this group. So as Alicia said, I will be presenting my proposal for the CDA-2 entitled Addressing Disparities in Pain Management. So just as a disclaimer, I submitted my first round in December 2020. I just received my feedback last Friday. So mainly today I'll be looking for some feedback from the group on how to improve, and I'll provide some targeted questions to think about throughout the presentation. I do plan to resubmit in June 2021. Okay. So some key takeaways from my round one feedback include some good highlights. So overall, they saw me as an excellent candidate with a good background in health disparities research. They liked my mentoring team, stating that I had a stellar mentoring team, including Amanda Midbow, who's on this call as my primary mentor, and my other mentors include Susan Frayne, Diana Burgess, and Rachel Kimmerling. Overall, they thought that I had a good conceptual framework, which I'll be going over briefly today. It's an integrated framework, including CFR, the Healthcare Disparities Framework, as well as the Anderson-Gelberg model. In general, this was a relatively high priority area. As many of you may know, the VA has really pushed for this whole health initiative and delivery of evidence-based NPTs in more recent years. And also, my reviewers thought I had an excellent integration of veteran advisors and veteran engagement throughout all three of my aims, which I'll go over. So some areas where I need help include better integration of aims in aim 1, which is the quantitative aim. One reviewer was wondering if it was essential to the overall project goals, so I'd like a little bit of feedback on that. In aim 2, which is a qualitative aim, more specificity more specificity on outcomes to be measured. And in AIM 3, reviewers did have some concerns with feasibility and wondered if it was comprehensive enough to support an IIR submission in year 3. So I present this slide to you just to prompt you to think about these topics as I go through, in a very brief and condensed manner, my CDA. So first I'll go into the background and then go over my specific aims, methods, and then we can discuss. As many of you may know, chronic pain has quite a high toll in cost per year in billions in the US in general and for the individual. Pain can cost up to $635 billion per year, which is more collectively than the cost of heart disease, cancer, and diabetes. In VA, it's quite a big problem with over 2 million veterans suffering from chronic pain. And in the U.S. in general, over 100 million U.S. adults are affected. There are health disparities in chronic pain and pain care, especially among veterans of color. So for instance, Black, Indigenous, and people of color have a lower likelihood than white veterans of receiving comprehensive pain management and assessment, including prescription opioids, are more likely to perceive discrimination when seeking pain care at VA, and are less likely to have their pain adequately addressed than white individuals, and are subjected to racial bias, including persistent provider beliefs that they have thicker skin than white patients and therefore experience less pain. Non-pharmacological pain treatments are guideline recommended by both the CDC and VA for managing chronic pain and are considered the first line of treatment for treating chronic pain. However, not all NPTs are evidence-based. From the VA HSR&D State-of-the-Art Conference in 2018, evidence-based modalities include behavioral therapies, including cognitive behavioral therapy, exercise and movement therapies, so for example, yoga and Tai Chi, manual therapies, including massage and acupuncture, and also forms of multimodal pain care, with one example being the collaborative telecare management of chronic pain. However, NPTs are used inconsistently among veterans of color and women veterans. So doing my research for the CDA, it seemed that there were a couple of different studies that found mixed conclusions about the use of NPTs, especially evidence-based NPTs. And this may stem from a disconnect with patient context beliefs and preferences. So for instance, in a recent study, American Indian and Alaska Native veterans were found to use more holistic and herbal non-evidence-based NPTs than the evidence-based, and the use varies across these different racial subgroups. One promising implementation strategy for increasing or enhancing engagement with evidence-based NPTs includes complementary push and pull implementation. So an example of this would be with academic detailing, in which academic detailers give information about EBNPTs to clinicians who then give that information to the patients. A complementary pull strategy would be bringing the EBNPT straight to the patient consumer, so bypassing the clinicians and delivering this information directly to the patient. As I was stating before, there has been a paradigm shift for chronic pain care, both in the VA and the U.S. at large. Over 18 VAMCs are considered whole health flagship facilities with a focus more on whole health and patient-centered care. And what this means for EBNPTs is that there are a suite of different types of NPTs available at different VAMCs. These are also included in the veteran benefit package. However, Kliegler also wrote a paper describing that effective strategies to disseminate these evidence-based NPTs must meet the needs of diverse veteran populations, attend to the needs of marginalized veterans, and reach veterans, providers, and other key stakeholders. So the significance of my CDA really focuses on unjust differences in pain treatment, which point to health disparities. Some of you may be familiar with this figure I've included. This is from the Institute of Medicine's critical report from 2002, which describes that differences do not always equal disparities. So for differences, here we see the quality of healthcare may be attributed to clinical appropriateness and need or patient preferences. So if there's a difference between white veterans and non-white veterans, and it's attributable to differences in their actual clinical needs, this is not considered unjust. However, when there's a difference in the quality of healthcare between non-minorities and minorities, that's attributable to these other factors, including the operation of healthcare systems and discrimination, then we can really consider this a disparity and something that needs to be ameliorated. And many of you may also be familiar with the giving tree, and I found this graphic which kind of highlights the need for tailoring evidence-based treatments for specific groups. Equity happens in this lower left quadrant. Equity happens really when we customize tools and identify different factors that would enhance EBNPT engagement among certain groups. Whereas sometimes we really focus on equality, where we evenly distribute tools and assistance to different groups without regard to this customization. And so that's what I really focus on in the CDA. In terms of my conceptual framework, it is a combination of 3 different types of frameworks, including an implementation framework, a healthcare disparities framework, and a more healthcare utilization concept-specific framework. I won't go too much into detail on this graph, but I'm happy to come back to it in more detail later in the presentation. But this is where I tried to highlight that these are the factors that will be measured in AIM 1, or the quantitative AIM, in the Gelberg-Anderson, including clinical need and enabling resources. The factors measured in AIM 2 include patient predisposing factors and providers characteristics. And in CFR, in a pilot AIM 3 implementation strategy, this is where I apply the CFR with everything kind of set into this multi-level context of healthcare disparities. I had 3 specific aims for the CDA. In AIM 1, I quantify unexplained and explained disparities in evidence-based NPT use using a healthcare economics approach called Blinder-Oaxaca decomposition. In AIM 2, a qualitative aim, I elicit multiple stakeholder perspectives necessary for designing this tailored implementation strategy in AIM 3. And in AIM 3, which is the aim that really uses this push-pull complementary strategy, I develop, refine, and pilot test the implementation strategy that enhances veterans of color and women veterans' engagement with EBNPT. The rationale for AIM 1 was a need to quantify unexplained sources of disparities in EBNPT utilization and identify actionable predictors that can be acted on in AIM 3, the push-pull complementary method. For this, I proposed a retrospective fixed longitudinal cohort analysis using 2 main databases, including the Women's Health Evaluation Initiative Master Database, which includes all of these different data sources, and data extracted from the VA CDW, where I get community claims data and also SAIL data on provider and staffing ratios. In terms of the cohort, I proposed identifying veterans using a chronic pain algorithm that's been published and will be identified during a fiscal 17 to 18 cohort accrual period. In terms of methods, my main independent variables for this Blinder-Oaxaca decomposition include race. So I have 2 main categories, white versus all non-white veterans, and also subcategories of white versus non-white, black versus non-black, etc., and ethnicity, including Hispanic Latinx versus non-Hispanic Latinx. Covariates were based on research indicating certain social factors that affect engagement with evidence-based chronic pain care, including marital status, urban-rural status, and service-connected disability rating. My main outcome variable is EV-NPT use, which is a dichotomous variable, and this is created from ICD-10, CPT, and STOP codes. And for this upcoming submission, I should mention that I will also include CHAR4 codes. And possible actionable predictors that I included in the CDA, but also are, I would love your feedback on other possible actionable predictors, include rates of referral to community care, provider and support staffing ratios, and facility rates of opioid overprescribing. Okay. So this is not my graph, but this is an example visualization of blinder Oaxaca analysis. So this approach really teases apart the contribution of explained versus unexplained factors on some kind of outcome. Originally, it was developed to look at the explained versus unexplained effect of certain social determinants on wage gaps, so the man and woman wage gap. And in this particular study, as an example, they measured the impact of unexplained and explained factors on Hispanic women's wage gap. And they found that the unexplained gap of 29 log points was the largest contributor to the total gap of 50 log points, and is considered the closest estimate of outright discrimination. So here, all of their explained variables include these factors, including region, metro, family, etc. However, they found that unexplained was the largest contributor to the difference in the wage. In aim 2, which is a qualitative aim, I wanted to triangulate multiple perspectives and expand on aim 1. The design of this was content analysis using in-depth semi-structured interviews, and participants include 3 specific groups. So veterans of color and women veterans comprising the first group, clinicians and staff treating veterans with chronic pain in the second group, and NPT practitioners who practice different types of modalities in the third group. In terms of recruitment, I proposed using random and snowball sampling, oversampling women veterans of color, using operational partnerships with the WAY and with the Office of Health Equity. And in terms of data collection, COVID-19 permitting, hopefully, if I do get this CDA funded, I'll have time to, or I'll be able to interview people in person, but I'm also considering interviewing people by phone. And veteran interviews will last about 60 minutes, with clinician, staff, and NPT practitioner interviews about half an hour. Right, here I have some sample questions from the interview guides. So for veterans, an example question would be, some veterans have said that their culture plays a role in how they view and manage their pain. Does your cultural background influence how you view pain and pain management? From the provider and staff guide, what kinds of information and materials about non-pharm pain treatments have been made available to you? And for the NPT practitioner guide, what are your experiences in using CBT, yoga, etc., with veterans of color with chronic pain? In terms of analysis, I will have 3 trained analysts, including myself. I do have some background in qualitative research and design, and also I proposed hiring 2 RAs with some extent of expertise who will be trained during the funding period. We'll develop a code book of a priori codes based on my conceptual framework categories. It'll be an iterative qualitative approach using constant comparison, and to ensure validity, we'll engage in reflexivity and member checking, where we'll deliver the results of our analysis to a sample of participants to ensure that what they stated is reflected accurately in the analysis. And in terms of aim 3, this is really the pilot test aim in which I propose developing, refining, and pilot testing a complementary push-pull package to enhance veterans of color and women veterans engagement with EBMPTs. The design for this includes a series of steps, with the first being modified implementation mapping using results from aim 1 and aim 2 to create these tailored decision aids, and then pilot test the aids among a sample of veterans of color and women veterans and clinicians. Okay. So this would be a 3-part process. So the first, at the end of aim 2, I would begin developing a needs assessment logic model based on aim 1 findings and identify the least engaged subgroups based on the Blinder-Oaxaca decomposition. In aim 2, I would develop provider and patient-facing decision aids based on the qualitative results of aim 2. And finally, I would pilot test decision aids using push-pull strategies and assess feasibility, appropriateness, and acceptability of these decision aids, with the goal of eventually conducting a full-scale hybrid type 1 implementation trial to assess the outcomes of engagement with EBMPT. This is just an example mock-up that I submitted in the first round of a provider-facing decision aid. So some key features include that languages are similar to the VA pharmacy benefits academic detailing service provider materials that they have available. They are included as an operational partner. NPTs are named explicitly as the first-line treatment for chronic pain in the VA. Providers will have upfront the evidence-based NPTs that are the best treatment options. And moving on to the slide on the right, one key specific feature of the decision aid is that providers will have this link to a decision matrix of NPT treatment options that are available at their local VAMC and instructions for referral. So they have all that information on this 1 or 2 pager. Right, this is an example of a veteran-facing decision aid, which comes about from the direct-to-consumer outreach approach. So, for example, if from aim 1 we find that Black women veterans are least likely to engage in EBMPTs across the board, I would develop a decision aid based on qualitative analysis from aim 2 that directly speaks to concerns with EBMPTs and engagement with NPTs among this group, with specific instructions on how to get started and what's available at their VAMC. Okay, so I know that was a lot of information thrown at you guys at once, but I do want to circle back to my questions and start the discussion. So I will So first, I would like to get general feedback from the group, and then I'll be taking notes while we discuss.
Thank you. That was a really interesting presentation and definitely a very timely topic. I'm wondering, I was jotting some things down, went along. I'm wondering if, I mean, others may have questions already. I wondered if it might be easiest for you if we start with aim 1 conversation, and then like if you go back and kind of show us some of, maybe if you pick a slide and then you could inquire. It's such a rich slide set. I want to make sure that I'm looking at slides. And I want to open things up for folks that if they have any comments or questions.
Hey, Sarah. I'll just chime in, and I just stayed on video, so you didn't feel like you were talking to a void of grace, nothing screens. So it's helpful after having read the reviews and then kind of seeing you present this again. I know we've talked about this more than once already. I think some reviewer comments. One is, I think one reviewer commented about the cohort. You probably want to pull a more up-to-date later cohort, which we could update, and that's fine. We can do that. And then I think for some folks, and this is me included because this is not my strength, and if Diana Burgess were on this call, she could maybe also weigh in since she's one of your secondary mentors. But I think some of the reviewers were interested in like what, and maybe struggling with what is the product of AIM-1? Like what does it look like as you think about integrating it with AIM-2? The findings from AIM-2. And I don't know if other folks on this call are kind of struggling with what this concretely looks like. This, the Blender Oaxaca decomposition was, as you know, completely new to me. And I feel like I got some understanding, but I'm still struggling a little with it. And that might be where some of our work is. But I don't know if anyone else has thoughts about this in terms of the methods, et cetera, for AIM-1.
I think that's a really good point, Amanda. I think this is novel to some extent, and so in that way, I think it's hard for us maybe to integrate the information as well, and so, you know, that makes your job harder in writing your grant, right? Because you really have to walk people through it and really hold their hand through things. And so I liked your question, Amanda, about, you know, what will be the product or the takeaway from this AIM specifically that you would ideally want?
Like a projected example, I think we talked about it a little bit yesterday in your mentor meeting. Like, it's always so frustrating, I notice, because having read transfer, you're like, I'm going to give you an example, but just know this may not happen exactly how I'm saying, because you feel like you're wedding yourself to that at some point. But like in your mind, when you think about this method, you know, what is an outcome that you might see? You don't have to answer that right now, by the way. It's up to you.
I mean, I would hope, and I don't know if I make this as explicit as I should in the actual application, but I would hope that the purpose of this would be to highlight that, hey, these are the groups that need some kind of tailored evidence-based strategy, or that need to be better engaged with EVNPTs. But I don't know if that's too vague.
Well, what I'm thinking is too, right? It may vary by site. Even within a site, it may vary by outpatient clinic or CBOC location, potentially, right? And, you know, once we start to wrap our heads around this, like the data, et cetera, it may be kind of more complicated of a picture than when we're at first blush kind of thinking about this. I don't know. I'm actually thinking alongside you, Sarah, and we'll have more iteration before the second submission. But yeah, I'm wrestling with like what I think we do need a good example. I think Alicia's right. We have to kind of handhold, and I mean that helps me as well as somebody who has you know my strengths are elsewhere in this PDA submission. So it helps me also think through ways that we may even improve this design, maybe even make some decisions about whether we expand the period of time that we look across for this cohort. Yeah, because I can help you more too with how do we use the CDW data and how it's best. Okay. Other thoughts anyone has? Yeah.
Sorry, I don't mean to hog things. I guess I have two general comments. One is and this might have come up from a reviewer, is that my understanding is that the race and ethnicity data in CDW is not the best. And because that is an aspect of what you're doing, I wonder if you had any feedback or pushback around that. And then, go ahead.
Oh, no, I was going to say that, so with one of my mentors, Rachel Kimmerling, we've been looking at validating data from the CDW that's been shaped using the OMOP, so the Observational Medical Outcomes Partnership Common Data Model, and we found that compared to self-report race and ethnicity, it's actually pretty accurate. So I would be mapping race and ethnicity from the CDW to these OMOP categories, which VA is kind of pushing for, and hopefully that would help with the concerns with validity of that data in the CDW.
I'll also say they didn't comment on it, actually. And the other thing I'll note from some recent work we did in discussions, and I can't remember if you were on these emails, Sarah, but with the Office of Health Equity, Dr. Moy has noted that the VA data for race and ethnicity is actually better than non-VA data, and that well, kind of nationwide, there's approximately 10% missing, and it varies by facility. Like our facility is worse about capturing race ethnicity. It's also what I've learned from recent data capture. But we're actually not that bad off. I mean, it's not perfect, but it's actually, and it's not when you compare to certain other demographic measures, that there's less missing data, but we're actually not too bad.
That's really good to know, actually. And if you have any,
I can talk to you more about that.
You could share with others. That would be handy, I bet, because that's actually not what I've heard in the past. And I guess it's old information now, and that would be super helpful for people to know, I think. One more thing, and then I promise I'll shut up for a bit. I'm thinking about, like, you're looking at different, groups of veterans, right? You're looking at different races, ethnicities, and then you're also looking at women veterans versus male veterans. And just in my own work and my own interest is CBT for chronic pain, and we've thought a lot about, who engages in that. And I wonder, among the groups, I imagine that there could be different reasons in existence for some differences that we see. For example, for women veterans, I'm aware that many women veterans prefer to attend a clinic that's a gender-specific clinic, right? And that could vary by facility. I think, Amanda, you were mentioning that there could be a lot of variability by facility. And so they may decline a referral for, say, mixed group, yoga or something, but might be open to a different referral if it's a women's only group. The other thing is, I think that we know from some of the research with women is that women will often have other responsibilities that may interfere with them having appointments or multiple appointments, especially like for the example of CBT, where people would have maybe weekly appointments. It may be difficult to schedule those appointments if you have child or family care responsibilities. So I kind of wonder about, the answers to these could be different depending on the group that you end up looking at, and has that been a concern? Because you're starting very broad.
I will say, so both Susan and Rachel on my mentorship team have done a lot of work with women veterans and have collected this kind of data and examined these types of concerns. So if I would expect that in the qualitative interviews, if we do find that that's a concern across a significant number of women veterans, so for example, having to deal with child care or other responsibilities or gender-specific clinics, then and that also was associated with uptake of EB and PT, then they would be pulled out as a specific vulnerable group, and that's where I would try to tailor the decision aid to this specific group. However, I do want to, in AIM 2, to focus on the groups with the highest need for engagement with these types of modalities. So it wouldn't get that granular in AIM 3, I don't think, but it just depends on what kind of data I'm able to pull from AIM 2 findings. That makes sense.
I'll just chime in too. I think actually, so Alicia's point, and then you noting, some of the work that Susan and Rachel have done, although I guess not in non-farm treatments for pain as much.
Rachel's done, yeah. Rachel's done in her women grant from 2 years ago. She did connection to CBT and
but probably not CBT. It's CBT for pain, but CBT
not
just regular. Yeah, good to know. Okay, but to me, this is another example of where, as we're hinting at your AIM 2 methods now, where like as we handhold and the reviewer, and that, I definitely don't mean that in a demeaning way because I usually need that hand-holding as a reviewer. I really need it. And I love it when someone will walk me through this, like a hypothetical example of how the data, which is rare. I don't always get that, but it's helpful. But I could see you maybe integrating some of the research that's known, or maybe, I don't even know if Alicia has a published study in mind that we could cite, and or what Rachel has learned from her work in CBT, even if it's not for pain, but with other I'll just say psychotherapies for now. But what sort of gender differences have been seen, and say this is what I might expect and might hypothesize is happening once, as we integrate AIM 1 and AIM 2 methods. I don't know if Alicia et al. Or anyone else on this call thinks about that or have other thoughts.
I like the idea of a hypothetical kind of walkthrough. I think it just makes it clearer. I was also unfamiliar with some of the methods in AIM 1, and I think having a hypothetical and couching it as like this is by nature of the methods generating the things that are going to matter, but these are things I might think matter, and then this is how it would play out, because then you can follow along kind of where things are going to go. You see the destination as opposed to it kind of, and it makes the aims also maybe look a little less dependent on each other when you're like, this is something I could find, and it sort of helps make it more concrete.
Oh.
I think that's helpful. I think, yeah, I do think this would be helpful for reviewers, and just, it may, once we're also all on the same page with your hypothetical example, we may be able to make the methods even stronger. Yeah. Nice to get less abstract. We did appreciate you talking, Alicia. Oh, I was about to say, you can talk again. We like when you talk.
I was trying to walk the line between, like, I don't want to monopolize, but I'm very interested in this. I continue to have questions. And I can also say to folks, like, if you have a question you want to put in the chat box, that's also great. So the idea here would be that there would be some identification of areas in need of remediation. And it could be, you could say, wow, there's really a deficit in the care of women veterans. Or you may say, oh, there's really this disparity that we think we're seeing here in the care of Black veterans, right? And then that would be what you would carry forward through AIMS 2 and 3 and kind of have more intensive focus on those identified areas. Is that right?
Yes.
Okay, that makes sense. And then is there any concern or any need for talking about narrowing? Like, 'cause I guess I could see maybe a number of things emerging in this first AIM.
Great point. Yep, this is actually a really good point. I think what you mean is like, will we tackle all women and all minority veteran issues that we see across the way? I mean, along the way, or are we going to prioritize them somehow? Is that what you're getting at?
Right. Yeah, exactly.
Really good point.
I'm sure there are numerous things going on, right? And then how do you
I love this.
that, right?
I think that's actually such a super duper point that I completely lost sight of. I actually think we should maybe say we're going to have an expert stakeholder group in such an instance that will involve our key partners, your mentoring team, like, because I could see Office of Health Equity. I know Friedhelm is technically on this call, but maybe multitasking. Your pain management partner, including your PBM ADS partner. I think that would be awesome. Actually, really, like, thank you, Alicia, for bringing this up. I actually think that's absolutely right. We will probably feel overwhelmed by choice because as it will get very complicated. And I think maybe it's already in there and I forgot, Sarah, so I'm sorry if I don't think we have anything like this, but I'm thinking I don't think we addressed what do we do with too many possibilities. Did we?
Yeah.
Did we?
We don't, but
Okay.
I think that would help also integrate the aims better.
Yeah.
And be more clear in the reviewer's mind, because that was one of the overarching. I can send you the slides for help.
Yeah. I do this all the time, Friedhelm. That's why I say that. It's very normal.
Yeah, that was one of the overarching criticisms from this first round, that it's just not well integrated or clear how we get from aims 1 and 2 and develop the logic model. I thought that it would be enough for the first round to kind of explain that, okay, we'll develop this based on a needs assessment from aims 1 and 2 combined, but if we're more clear with examples and say that we're going to bring this information back to our stakeholders and then have them weigh in on the specific groups that need to be targeted, I think that would make it more clear.
Yeah, and I think we frame it like saying that we're aware that several priorities, sort of, maybe even use that term, priority groups will emerge, and also just noting, feasibility concerns. I would say, yeah, intersectionalities is a really good point, and I would say exactly right too. And I would say that since this is, and the reviewers also really noted a key strength was strong partnership engagement as well. So I think they would actually really like that if we do have kind of a multi-stakeholder group, including actually 1 or 2 veterans, ideally, to help weigh in. So just noting that we believe we will identify several priority groups and maybe address, as Jessica Merlin, who I think also goes by Jessie Merlin, but I'm not sure, noted in the chat that there may be certain intersectionalities. So that is a good point. It's funny because there was like a million details when we first did this first submission that we felt like we paid attention to, which is why this process is lovely. But yeah, I think that's actually a really good point. Okay, I'll quit talking now, Sarah. Sorry.
No, that's good and that's helpful. In terms of the intersectionality piece, I did include that in one of the first drafts, but then it got a little muddy. But I guess Jessica or Jessie, would you have a suggestion on how to include that or address that?
If you want to talk, or you can.
If you want to talk, or you can just no pressure.
Sorry, I don't mean to be like a stealth comment.
Oh, no, totally fine.
So, hey, this is Jessie. I first of all, great project and fantastic talk. I think just maybe along the lines of providing examples, and I think it was also Alicia's comment that made me think of this. Just, if you find that, in your early work in the project, you see some hints that there may be, that Black women, for example, or where there are disparities, then you may want to do X, Y, Z in future aims, and just kind of calling out how calling out intersectionality specifically and how being a Black woman is different than being just Black and just a woman, like that sort of thing. You may just want to add that nuance to bring it alive for people a little bit more, maybe. Yeah.
And yeah, I apologize. This is a very condensed version of my CD. I might include examples like that, but I'll make a note. It's just hard to pack all of the information in such a big project in a short presentation, but I think that's a great point. I'll definitely
of course, yeah,
incorporate that moving forward. Thank you.
Oh yeah.
I think there are people who have lived the CDA as a mentor or an applicant on the call. So this is my first CDA experience. So I will say, having put in merit awards and other query work, this is definitely one of the most giant things I've ever had to help with. So it's hard to ever succinctly describe a CDA. Did you want to advance to the end and just cover anything around the training plan or anything around those?
Oh, sure. Yeah, I would love if anyone has any suggestions on specific opportunities or didactic coursework that would help me flesh out my training plan. One of the reviewers' concerns was that I need to include more specific examples of being trained in chronic pain and non-pharm treatments in a meaningful way, because a big part of the CDA, if you aren't familiar, is that this will be what turns into my VA career. So if anyone has any suggestions for comprehensive chronic pain and NPT training or opportunities that they can think of for training appropriate for postdoc mixed methods.
I was going to throw out there that after we discussed a little bit in the mentor team around the chronic pain NPT piece. Since Sarah's not a clinical psychologist, she doesn't, naturally have this clinical experience. So we're thinking we'll just propose shadowing locally across pain clinic, et cetera. Oh, perfect. And Jesse weighed in. And then I don't know if anyone has thoughts on that or ways to expand that, because that just somehow doesn't seem like quite enough. But given the complexities around NPT referral and maybe also shadowing the whole health coach, it's a bit of a beast to wrap your head around. So I don't know if anyone has any other thoughts.
Hi, this is Una from Dallas. I'm joining a bit late, but I was just going to echo the comment about joining the USASP conferences. But I think that shadowing is a great idea, and I think it's invaluable to attend any type of interviews where you learn from the patient about their experience with pain. And I think that's probably the best learning experience, where you can either interview themselves, or as Alicia said, shadowing the whole health coach. But hearing it from the patients are invaluable. I see patients in clinic all the time and learn every single day from them. I recently presented my research to the veteran, engagement panel, Alicia, through the Pain Corps. That was really helpful to get a diverse set of opinions and expertise from individuals who all have pain, and that's quite a diverse group as well. So I think as much face-to-face patient contact as you can get, where you hear directly about their lived kind of experience, that is so helpful at all levels.
Thank you. That's a great idea. Is there a separate opportunity for veterans to present the pain opioid core? Is that a monthly kind of meeting, or a core veteran engagement panel? Okay, great.
So the core veteran engagement panel is is they meet at least monthly, but they've been meeting actually more than monthly here lately. And I can arrange to introduce you to our coordinator who can set up a meeting. We do get priority for early career investigators, and this sounds like kind of a perfect match. And you actually work with someone who walks you through so getting ready, identifying your specific questions, and getting like an interview guide, and then it's professionally facilitated. And you're kind of a spectator and there to answer questions, but I think it lets the investigator get a better sense of really what the veterans, their actual input is, right?
Mm-hmm.
So, and that could be something that you could think about including in different spots throughout the plan, right?
Mm-hmm.
Maybe you think we want to do a little bit of that in AIM 2, and this might be a component of that. So definitely we can email back and forth and talk about that.
Mm-hmm. That sounds great. Thank you. And thank you, Sarah and Jessica, for those suggestions as well. Interest at the time. Does anyone have any other overall suggestions or impressions? I know we're wrapping up on the hour.
No, I guess, can I just ask a random question about, because I know that the reviewers raised marital status measurement. I do think that's going to be a problem for us unless, I guess I just want to know if anyone has ever successfully measured marital status in their projects without asking the participants directly. If there's something I've missed.
I never have. I'm trying to think. I mean, sometimes when I'm doing chart reviews for patients, I look at their emergency contact, and that's a way, because it says usually the relationship to the patient as their emergency contact. And so it's not a perfect measure by any means, right? You could have all sorts of reasons that your spouse would not be your emergency contact, or or your spouse could have passed away, but you didn't update it. But that, when I'm doing chart reviews, that's like one way I have a proxy before I meet a patient and have talked to them to try to understand their relationship status.
Okay. Yeah, I mean, the reviewers raised it, and it is a question I don't think it's easy to get. I mean, and not easy. I don't know if it's possible to get.
Yeah, if no one else has anything, any other questions, then I'm happy to end there. Alicia, I saw you unmuted yourself, so go ahead.
Sorry, I have so many questions today. So first, could you say just a little bit about AIM 2? Because I know we spent some time talking about AIM 1. So AIM 1 is identification of specific groups, right, where there may be a need for some mitigation. And then it sounds like maybe a discussion with partners, or like prioritizing, or even seeing what's feasible, like what could reasonably be addressed, right? And then AIM 2 is then actual interviews with patients, clinicians, and others to get more information about how those things would be remediated. Is that right?
Yes.
Okay.
Yes, so AIM 2, the primary goal of that AIM is to get information about how these individuals get information about EBNPTs, what could be tailored in a decision aid in AIM 3, basically kind of setting the tone for developing decision aids in AIM 3.
Okay, that makes sense. Thank you. I just didn't know if there was anything that you wanted to ask about that. It looks like the reviewers were looking for additional specificity about what you hope to come away with from that. And it's probably somewhat difficult, and my guess is that the concerns will be different on the part of clinicians potentially from patients.
For the outcomes to be measured.
Right.
Mm-hmm. Yes. I think they just in general wanted me to be a little bit more detailed on the types of information that can be gleaned from the different groups and how those will be integrated into A3.
That makes sense. And I guess to the extent that you can do it, I think maybe coming up with some concrete examples of maybe some things that you think you'll find, because my guess is that you have some ideas about where there are going to be needs and disparities. Using those examples, walk with the reviewer through that. I said hand holding, and I meant that in the best way because I like it when my hand is held through a grant.
I definitely
with the reviewer, like using an example through there to say, like, this is what we might find. And if we find that, then AIM 3 will be developing the push-pull method, right? That you'll then be doing a feasibility pilot, it sounds like, for a future IFR. So really, AIMS 1 and 2 are really building to that. Is that right?
Yes.
Okay. That's good.
Yeah, in general, I think the hand-holding is a great tip, and using more examples, because I think that they would like more specificity and detail. So that's helpful. Thank you.
I have to run. Sorry I interrupted you so many times, and I will.
Okay.
I'll talk to you later. Great job.
Thank you. Thank you for
everyone.
presenting today, and we look forward to having you back when you can tell us about your results from AIM-1 after you get funded in AIM-2.
All right. Well, I'm knocking on wood. Thank you so much for the opportunity, and thank you all for your feedback. Please feel free to email me if you have any other questions.
Great. Thanks, everybody, and talk to you again next month. Bye-bye.
Bye.